Hi, it's Dr. Robert Seichert. Thanks for watching a new episode of the Doctor Podcast Show. And today we have a great guest, one of the world's leading experts on hearts and heart disease and AI related to hearts and heart disease. Our guest today is Dr. Natalia Trayanova. Dr. Trayanova is the Murray B. Sachs Professor of Biomedical Engineering, Professor of Medicine, and Professor of Applied Math and Statistics, the director of the Alliance for Cardiovascular Diagnostic and Treatment Innovation, which is known as ADVANCE, and director of AI Research, Health and Medicine, Data Science, and AI Institute, all at the Johns Hopkins University. And Johns Hopkins is one of the major universities and major medical centers, one of the top medical centers in the world, in fact. So I'm really pleased that Dr. Trayanova could join us today. Dr. Trayanova specializes in cardiac arrhythmias, which is abnormalities of the heart rate or heartbeat, and also specializes in heart pumping dysfunction or abnormalities of the heart muscle. And she is working for many years on novel or new anti-arrhythmia therapeutic methodologies using AI and imaging. Dr. Trayanova has published over 450 scientific papers and has given over 370 invited talks around the world on the subject of heart disease and new technologies. She has numerous patents in the field as well and has been involved in several FDA clinical trials for heart disease. She's a fellow of every American and European cardiology society on the planet. So she's really busy. And she's now working on creating an AI-powered digital twin heart so that basically we can all have a digital heart that resembles our heart completely and will be extremely useful in treating and preventing heart disease. So, Natalia, thank you very much for taking time today to speak with us. This is a very important subject because heart disease is the leading cause of death in the USA and probably around the world. So thank you very much.
Thank you very much for having me. I'm really thrilled. I love to talk about the science that we do, about the innovations that we develop. It's just so much fun. Thank you for having me again.
Sure, it's our pleasure. Thank you. Now, how did you become interested in heart function and heart research? And by the way, what did you get your PhD in?
I'm a kind of unusual specimen, actually, in that respect. I don't have a pedigree, if you will, because I have a bachelor's and master's in physics.
Physics, wow.
In physics, yes. I was born and raised in Bulgaria, in Sofia, the capital of Bulgaria. And I actually started my PhD in biomedical engineering there. I completed it there, but meanwhile, I was here in the US at Duke University on a fellowship from the National Academy of Sciences for like nearly a year. And then I went back and I defended it. So anyways, when I came to the US, I really didn't have a mentor. I didn't have an advisor. I didn't have anybody to say, well, that's what you do when you want to be in academia. I look at my students now and my postdocs and I'm like, oh, I can tell you everything, what you need to do. I had nobody. So
you accomplished a lot without any mentoring.
Yeah.
You figured it out by yourself, which is very impressive.
I had to. Yes, it's a difficult road, and if you look at my at my pathway and my achievements, it's sort of the curve goes like this and then went like this. It's not the standard sort of linear progression.
Right. And you're still going like this from everything I've seen that you're doing, the incredible research. So let's talk about that. Tell us what a digital twin heart is.
So it's actually the digital twin of the heart. Yes, it is basically what a digital twin is. It is a virtual representation of a system. It's not a new concept. It came from manufacturing. 40 years ago, the concept was introduced actually. But recently, it has made really big waves, and it's one of the sort of most talked about new developments in medicine. And we have been working in cardiology, but recently I turned around and now it's in oncology, in pulmonology, in a lot of other disciplines of medicine. So creating a digital twin of a system is this virtual representation of the system, of its parts and their interactions. And it is based on the characteristic of the system. It sort of interacts with the system. For instance, a decision that is made in the digital twin that goes back to the original system. It exists in environmental sciences. It exists in a lot of other aspects of sciences. In medicine, that would be a virtual representation of an organ, or ideally of the patient, when we have the interaction of all organs together. You know, that would be the goal. Currently, we are working at the organ level, and I work, as you said, in heart disease, particularly in heart rhythm disorders. And our goal is to create a digital twin of the patient's heart. That digital twin basically would represent what is the disease in the patient's heart. And then we try to predict what's the prognosis, if you will, or what is the best personalized treatment using that digital twin. In my lab and in my center, it's basically interconnection between artificial intelligence technologies and digital twin technologies. They are two separate entities, if you will, because one is very mechanistic. The digital twin is mechanistic. You can, like in our digital twins, we can incorporate processes at the cellular level and then see what is the emergent phenomena at the whole heart level. So for instance, if we are representing the heart of a patient who has some, you know, gene, has a different genotype from the standard patient, then we will incorporate that. So all these things become part of the digital twin. On the other hand, AI is typically an approach where you learn something, you learn patterns from a big amount of data.
Right.
So they are very different. One is really mechanistic representation of the patient heart, and the other is learning behaviors and patterns from a big data. However, we have been able to incorporate, kind of link them in a way, and use artificial intelligence to generate some components of our digital twins. For instance, when we generate our heart digital twins from some sort of image of the heart, right? It has to be.
Where do you get those images?
Yeah.
That's
so typically we get them from MRIs, clinical MRIs from the patient. We get them preferably from what's called late gadolinium enhancement. This is basically a contrast enhanced MRI. And we like to have the contrast enhanced MRI because then you can see if the patient has scarring in the heart. You know, patients get scarring from infarcts. As we age, we develop fibrosis, remodeling. All that you can see in a contrast enhanced MRI scan.
So basically the heart is a muscle, but with this enhanced contrast MRI, you can differentiate muscle tissue from scar tissue.
Exactly.
Various types of diseases.
Exactly. We also can incorporate other, we can use, or sometimes we can fuse different types of images in creating the digital twin. For instance, you can use a CT scan, also contrast enhanced CT scan, that represent that you can see the fat distribution, adipose tissue. It can be on the surface of the heart, on the epicardial surface. So actually, we have studies where we show the penetration of adipose tissue in the organ itself, within the myocardium, and that is also arrhythmogenic. So all these structural remodelings, the scar tissue, the adipose tissue, they are very arrhythmogenic because normally electrical impulse, which is the heartbeat, propagates through the heart in a very coordinated way.
Right.
But when it encounters scar tissue or fat, actually it can kind of attach to it. It basically doesn't propagate through correctly, but attaches to these sort of remodeled parts. And what it does, it comes back on itself. So the heart doesn't have a chance to relax after the electrical beat, fill with blood, and then pump the blood out. So if you have an electrical impulse that doesn't go through, goes through, then there is a pause, feeling another impulse. If we don't have that process, but you have an electrical wave that is recirculating because it caught somewhere in this, then you have the heart is trying to contract, following, because the electrical wave is the trigger for the contraction, is trying to contract following that electrical wave. And you get this sort of uncoordinated contraction of the heart that can be lethal because there's
Can't
no
pump blood.
it can pump blood. So that's why we want to represent in our digital twin. So that's why I got to that point, is why do we want to have contrast enhanced scans, is to represent these structural remodelings. We have also used PET scans that show inflammation. Inflammation also changes the properties of the cells, and then we can incorporate that or fuse it with the other imaging. So we create these personalized digital twins from these images. We start with the images.
Right. So I can imagine how you get these images, the MRIs, the CAT scans, the PET scans, put them together. But one of the most important things that are hard is it has these conduction fibers, almost like nerve fibers, through which the electrical signals travel and stimulate the heart muscle to pump in a very coordinated, symmetrical fashion. How do you image these microscopic electrical impulses that go through the heart?
We don't. So we don't image that. So I have to take one step back and say, you could, it just depends what is the purpose, right? You have to design your digital twin or your approach to the purpose of what it will be used for. What we want to do with the digital twins is to predict non-invasively what would be the best treatment for arrhythmia in a given patient. If you want to do that, so if we want non-invasively, I cannot go and poke in the heart and say, I want to measure that electrical property of that cell. We cannot do that. So we have to make assumptions, and then we have to test these assumptions in a large sort of sensitivity studies, also in the clinical studies, and see what assumptions make sense for a particular disease, what assumptions make sense for another disease. And that's what we have done. So some of our digital twins are actually different for different diseases. We have digital twins that the most common human arrhythmia is in the atria, which are not the main pumping chambers, but it is one of the largest healthcare expenditures, atrial fibrillation.
Atrial fibrillation, right.
Atrial fibrillation.
Yeah, many of my patients have that, people in their 70s and 80s.
Exactly. And this is a disease of the elderly, actually. And as we age, the probability of having, nearly 2% of the population on Earth has AF.
Yeah, it causes strokes and all sorts of.
Exactly. Huge problem. And that's why you want to detect early, subclinical, we have all the Apple Watch studies and so forth.
Right.
But so one of our big avenues of research is actually trying to figure out how to treat best patients with atrial fibrillation in a personalized way.
Right. And so let me ask you this. So what you're doing is putting the images of the heart together, putting the scar tissue images, the fatty tissue, maybe inflammation of the heart muscle, coming up with patterns that AI then looks through, and eventually...
Not exactly. Yeah, not exactly. Okay, so I said I will get to the way they are connected to AI. Right. So what we do is the imaging is basically the scaffolding, if you will. It's right. It's that's the scaffolding of the digital twin, and you have inside all this remodeling. And then what we do is we discretize it in small elements, almost of the cell size.
Cell size, wow.
Almost, yeah. They are what you create is what's called a computational mesh. This is discretized, this object in elements that are about 250 to 300 micron in length, about 300 micron, and so to each of these little elements, we assign cellular properties. Okay, so we represent actually quite explicitly through equations the ionic transport across membranes, as well as the calcium cycling in the cell.
Really?
So
Wow.
Yes, so if the cell has remodeled properties, we can incorporate that in a regional manner. We can say, but we do not know that exactly in the patient. So what we know from studies is that if you have a scar, very often around the scar, you have what's called a gray zone, which is kind of in between scar and normal tissue. And these are cells that have altered properties. They are kind of semi-viable. And we know from studies what are these properties. So whenever we create from the image, the digital twin, and we have a scar, and we have this gray area that we also represent in the digital twin, there we assign these remodeled properties. We know what they are from other studies.
Right.
We just incorporate them there. If you have inflammation, region of inflammation, we know what is happening, how cells change. So we incorporate these properties. So ultimately you get a quite heterogeneous object, which is this personalized version of the patient. Not every aspect is personalized, as I said. A lot is personalized, but some of the cellular properties are not, that have to be acquired invasively. And then what we do is, we do not say, because of that, we do not say that we are representing exactly how, let's say, atrial fibrillation would look in this patient. But what we would do is, we would poke it at different places, give it electrical signals, and see whether arrhythmias originate.
You mean poke it on the computer instead of
on the computer, virtually, poke and prod in the way you cannot do in the patient.
Right.
Exactly. So in a way, what you're doing is you're assessing the arrhythmogenic propensity of the substrate, what's there in the patient. And so we poke it. Oh, can it originate an arrhythmia? We poke here, can it originate? And then we find these bad locations that turn out to be the perpetrators that sustained the arrhythmia. So they are pretty much determined from the structure, but not every structural change does that. So this whole digital twin, you are able to figure out where are these perpetrators. They are not too many. And so what we are doing better than in clinical practice is, I can say where to ablate. And these are not huge areas. They are very targeted. So if you compare to what is done currently in clinical practice, both in atrial and ventricular arrhythmias, they ablate very large areas. Ours is very targeted, number one. Number two, a very, very important benefit of digital twin, an advantage of our approach is that once we predict where to ablate in the digital twin, we actually initiate this protocol to find where something else is happening after you ablate. You know that so many patients get ablated, go home, a few months or maybe a year, they come back. They redo procedures. I mean, just the hospital, the healthcare expenditure of that.
Huge.
In addition to that, very often areas of the heart ablated that don't need to be ablated. And so the organ becomes, functionality of the organ is diminished. So what we do is, when we predict where to ablate in the digital twin, this is not our final prediction. We then repeat this protocol of testing what happens, because ablation is actually you're creating new scar.
Right.
You're creating new scar. In a way, you can think of it as you're having a complete new landscape for the wavefronts to attach. Scar that is generated by a lesion can be very arrhythmogenic. So we assess whether the scar combines, the new scar combines with the old scar or native fibrosis or native inflammation to create this new landscape that can be very arrhythmogenic, even more arrhythmogenic. So we test again, and if it is arrhythmogenic, we can predict where the targets are. And then after we repeat that several times, we have no targets anymore, no new activity. And this is the final ablation target that's personalized to this. And that's what we export to the procedure room. And that's what gets ablated in the patient.
Right. So I just, for people out there who are not cardiology experts, we use the word ablation a lot. Can you just explain what ablation is and explain how that gets rid of arrhythmias or abnormal heartbeats?
Ablation is when a piece of tissue in the heart is basically rendered no longer capable of conducting electrical signals. That can be done. That is typically done by threading a catheter in the heart. Can be in the atria, can be in the left, can be in the right ventricle. It's just basically threading a catheter, finding the appropriate location, and eliminating. The elimination occurs via delivery of radio frequency energy, which is a burn, basically creating a burn. There is cryoablation that works only for atria, and it ablates close to the pulmonary veins. It's kind of balloon that freezes the veins. And there is a new therapy called pulse field ablation, which is giving the delivery of these very quick pulses that electroporate the membrane. And so by electroporation, basically the ionic content spills out and the cell is no longer capable of conducting electrical signals. So those are the three available technologies, with the latter one being still, out there being tested.
The reason ablation is currently being done is because medications haven't worked. In other words, cardiologists have tried various medications to get rid of the arrhythmia. It either doesn't work or it works very short term. And
it's also sort of, I've talked to patients and they really would prefer to not be on the drugs because it's affecting lifestyle as well,
Yeah, they have side effects.
Yeah, they have side effects. And so many want to be, to have the ablation and be done with the arrhythmia.
Right. So let me see if I can summarize. Up to now, we've been using sort of a shotgun approach of ablation, where we ablate rather large parts of the heart where we think the arrhythmia is originating from. What you're doing is allowing us to kind of be very specific and target much smaller areas of the heart that need to be ablated. By doing that, you're causing less damage to heart muscle, and also you may reduce the recurrence of another arrhythmia because of the ablation tissue that you damage. Is that a good summary?
Yes, the second benefit is very important because it basically, we are able to predict what's going to happen in the future. We know what's the new substrate, and it's gonna click at some point somewhere. Some signal will come and catch there, and that cannot be done. That cannot be predicted. There's so much in ablation. There has been so much emphasis on developing better mapping system or better catheters for ablation, durable ablation. Control of the force, also irrigation and so forth to contain the ablation to a desired area and so forth. But no matter, even if it's the most perfect ablation, and even if you are able to not use digital twin to predict perfectly where to ablate, you still don't know what's going to happen after that. So it's a twofold advantage. One, you're predicting pre-procedure what are the targets that are smaller that has currently been done. And number two, you're saying what can happen in the future. And it's interesting, we have had a number of studies in which, we see one of our target, retrospective study to which we are blind to the clinical outcome. They have ablated the target, patient has gone home, come later. Like I was just looking in a paper that we were working, the patient came 7 7 months later, 2 targets ablated exactly where we predicted. So should that have been done before the procedure?
Right.
It would
Now,
have been
I read recently there was an article about you in the Wall Street Journal where they were talking
Yeah.
about this procedure. It was an amazing article. And it mentioned that there was a patient who actually wanted you to see him first, figure out where to ablate, and then kind of guide the cardiologists who were going to ablate. So I was fascinated by that. Tell us how that worked out.
Actually, the article also mentioned the FDA-approved clinical trial. It's an ID. We have a FDA-approved clinical trial for testing the utility of the digital twins in ablation of persistent atrial fibrillation. So FDA approved us. We are single center because the technology is here. So we have done 53 patients now already, and this is actually very interesting because it's a randomized controlled clinical trial. So the patients are randomized to pulmonary vein isolation, which is an ablation only around the pulmonary veins and the atria, versus our approach. So these patients, they sign consent. We can talk to them, email, we know they,
Right.
we predict for them. So those are the patients that are in the clinical trial. But if somebody comes to me and says, hey, I would like to know what's happening with me, we can do it, right? If their cardiologist says, sure, let's do it. Let's have an MRI. Okay. I've had a few cases like that, and that was one of them. So that's a patient outside of the clinical trial, because in the clinical trial, according to the what was in the protocol, our clinician collaborators, they will ablate where we predict. That's unless there is a safety issue, but
Right.
otherwise they have to ablate according to the clinical trial. Here, for these patients that are not part of the clinical trial, they can come to me and say, please predict what's happening with me. And then I'll take it to my, cardiologist and see where we go from there. And we did that. He's actually somebody who is, I believe he's an alumni or at least a benefactor to Hopkins, but he's known our work. I've talked to him numerous times. I've looked at his scans and he's like, okay, I'm going to have an ablation. Can you please tell me, what you think? And we did that for him. As a matter of fact, he lives in California, and he was, what we did is, I have an MRI specialist. We needed to take a good MRI so you really can see where the fibrosis is. So that my MRI specialist, he was on Zoom there with their technicians, and they did a perfect scan. We were able to take a look, and that's how it worked.
Well,
so it was done, and we did the analysis here. So it was done in another clinical center, not here.
That's pretty amazing. How accepting are interventional cardiologists of this? Are they feeling confident? Oh yeah, we'll do what you found? Or are they saying, oh, I've been doing this for 20 years. I've done, 1,000 ablations, and my ablations work really well. I don't need this new digital twin heart. What's your experience with that?
It's a rough road. It's a rough road. But
I know my doctor colleagues, so I could have predicted that it would be
a rough road, but not with my. So first, I want to say my Hopkins colleagues are absolutely amazing. I mean it. They have been very accepting. They are keen to, what ultimately it boils down to. If you can convince a clinician that you'll do better for their patients, I think that they're generally really open to that. They don't have too much time to spend understanding and having a full grasp. But if you are able to convince them that the technology could benefit their patients, I think that they are really willing to. There are so many clinical EP colleagues from all kinds of institutions that have been following my research for a very long time. And they like really like my talks. They come to my talks. They sort of actually know what that is. My personal problem is that the technology, I cannot move the technology to another clinical center yet. That is my problem. I think many people would be willing to try it actually. And
Right.
that is my problem. And that's where AI comes actually to aid in that. So why I cannot do it in another center, we have to do it is because, as I said, we have this resolution, very high resolution, we have its cellular properties, and it's executed at a high performance computer here at Hopkins, right? Now, we don't have that in the hospital or I mean, it's very automated. So, you know, it's basically push of a button for majority of it, but I don't have somebody there who can run it. And it's an issue because I'm running it on high performance computer and computing infrastructure, and sometimes it's busy. So I have to call and I have like, oh, I have a patient, we nearly, so there is like some of that. So what I want to do is, and because of that, it takes also some time between the image being acquired and when the procedure is executed. I don't want that time. You know, now they schedule the patients. There is no problem with the scheduling typically. But for me, I want to make this process very quick. I want to make it quick, automatic, and executable in the infrastructure that's available in the hospital. And that's my bottleneck right now. And that's where AI is coming into big help. So how AI is coming into big help is, first of all, we developed a neural network that segments the images. Before it would take like 4 to 6 hours. Now it's less than 15 minutes.
Really? Wow.
It's actually 15 minutes with a specialist taking a look to see that everything is okay. There's something is not missed. So it's much, much faster. So this is number one. So the AI based, we train a neural network to segment the images. And what's important is segmentation has been, people have used that for segmentation, but the important thing is for the atria, we do that on the atria in the thin walls and with the fibrosis. And so that's a big innovation in using AI. In addition to that, what we are doing is what I do is to actually predict where to ablate or how the arrhythmias is occurring, the dynamics of that arrhythmia. What I do is I calculate these equations that govern current flow. And so the equation of current flow in the heart combined with the equations for the cellular behavior in every of these cells, and they are like 10, 12 million. So it's a massive system of equations that gets solved on this high performance infrastructure. And that's what takes like a couple days or sometimes more, depends on how many, trials we have, because you might have a new locations and so forth. So I don't want to do that. I don't want to have these extensive simulations and use of high performance computing infrastructure. So we are developing a neural operator that can learn from executed simulations to predict the outcome of the simulations. So that's another, and this is 30 seconds.
Wow, that's amazing. So ultimately, once you get enough patients in the trials and in your experience, and you get a huge database, could a patient come to you, you image them, and you can see exactly where the problem areas in the heart and send a report to the interventional cardiologist? This is where you go and it's done? Is that what the future is?
Yeah, that's the goal. That's the goal. I mean, yeah, exactly. And so that's why I wanted to do the clinical trial myself. It is, you understand the way things move. Technologies, when you work in interventional cardiac EP space, technology, when you have a technology in the catheter, it's very well accepted. It does better job. You can feel it, right? But when you have a technology like mine that is out there, it's, that takes some time. So, or not just some time, but it takes, acceptance, as we discussed previously. So getting my own clinical data from the clinical trial that's a randomized controlled actually was very important for me. You
Right.
know, I don't want to go ahead with convincing anybody to do anything until I have the clinical trial data.
Right. It all comes down to data, basically. I
Yeah,
know
I might,
you yeah, you recently published a major paper in Nature Cardiovascular Research, which is one of the top journals. And I think once cardiologists read that and see it and see more
yeah.
articles from you, they'll become more accepting. Can you tell us what that study showed and what that paper was about?
So this paper, it is in this paper we used, it's like it was a prospective study in which enrolled patients who enrolled. We just used their scans. We created the digital twins, and we actually. So let me formulate it. You know, the clinical trial is trying to predict, trying to demonstrate that digital twins have really important advantage in ablation because patients will not come back for the ablations. That's the goal. That's my goal in that clinical trial, right?
Right.
Okay, so when you're doing the clinical trial, as you're doing it, you learn new things.
Right.
Always. And these new things, I cannot implement them because it's a clinical trial and I have a fixed protocol. So I have to achieve the goal, demonstrating, but that it works or it's better in this patient. But what we learn is that I talked before about the new landscape after you ablate. You have scar and you have this combination of native remodeling or native disease before the scar and how that combines. By using the digital twins to look at these new landscapes after ablation, we found some interesting things. That's something that seems needs to be ablation, and now in our clinical trial is ablated. It doesn't need. Very interesting, because the landscape is so different that even if you ablate a target here, something that attached an arrhythmia right here stops attaching because it gets overwhelmed by the new landscape, kind of. So you can even further improve what we are doing with the digital twin. And we showed that you can decrease the number of targets actually by 64% by doing that, this careful analysis. So it's an additional analysis to what we have in the digital twins, in the clinical trial. It demonstrates what else you can do that's even better. Now, once you know, so this is further advancement in the digital twin and their use in potentially for ablation. So that was the goal of that Nature cardiovascular research paper. Also, what is important is we are developing the ablation in such a way that we prevent iatrogenic arrhythmias. Those are really bad arrhythmias that occur around the scars following ablation that are very difficult to terminate. We also demonstrate that we can prevent that. So what is really a key of all that is that we are treating the digital twin and figuring out the optimal personalized approach before we are treating the patient. We treat the digital twin of the patient, find out what's best, and only then it goes to the patient.
There's zero risk to treating the digital twin.
Right? Exactly. There, you know, I try, oh, well, new arrhythmia occurred. Let me catch that, right? You can do that. You can prevent any iatrogenic, post-ablation arrhythmias as well. Anything that
I have patients who feel like they've been chasing their tail because they have an ablation, it works for a while, they're thrilled, and then they get a new arrhythmia and they have repeated procedures. So this, I think, will avoid that and prevent it. It's amazing work and technology. One of the other things that I'm amazed by the work that you do is you've been able to combine medicine, biomedical engineering, radiology, math, put it all together. How do you get this team to cooperate and work together? And and get this done. It's a pretty amazing accomplishment. How did
I
you
have
achieve
a I
that?
have a specific strategy.
Oh, what is that? Tell us.
My secret is to have students and members of my team that speak clinic very well. Clinical language that I call them bilingual. They can speak technology, they can speak math, they can do engineering.
Right.
They can talk to clinicians, to radiologists in their language. I don't believe in collaborations with clinical partners meeting in the middle. Oh, we're going to collaborate. They have to come here and we have to come here. No, we go 95%. Maybe after a while and they understand what we're doing, maybe we'll move to 80. But that's about it. I think that's what it is. I think it's very important for my students to be able. So what's happened is the way my team works is we are essential part of the team at Hopkins, of the interventional cardiac intervention electrophysiology team here. I mean, this whole thing, working on clinical subject, having a clinical trial has changed my the way I live is because now 2 days of the week I have to get up very early and have clinical meetings. One on the atrial arrhythmias, the other on the ventricular. Normally I'm somebody who has a degree in technology. I'm a late night person, but now my entire team, everybody gets up. I get up at 5 something and I'm there in the hospital. And we are all there and everybody is there and everybody participates. And it's become such a team that it's like all the ideas abound. There is no difference between clinical fellows work in my lab. I have the first, actually, this is interesting. The first author of this Nature Cardiovascular Research paper that you just mentioned, he's a ablationist, clinical EP from Japan. He's never done math. He's never done simulation. He came in my lab, learned how to do it because he cannot practice here. What he does is he learned how to do it. He does the virtual treatment in the digital twins. He's really good at it because he has the eye for the arrhythmia. And so they work together. I have now 2 doctors. I have a cardiac EP guy from Germany working in the lab.
Wow.
Just he's more into the AI side, but yes, and they bring data, and then we all work together. It is essential. My people learn from the clinicians in the lab. The clinicians learn from, and the clinical fellows learn from the lab. Everybody is so much. There is so much sort of interchange of ideas and knowledge, and all the papers are combined. It's expertise of everybody that's on the team.
It's a very stimulating, exhilarating environment. A lot of smart people working together in a team. Sounds like you like challenges, because at the beginning of this talk, you mentioned how you had a rough time getting started. So you're always looking for difficult challenges, even now. How many people in your lab at Hopkins?
I have 9 PhD students right now.
Wow.
I have 1, 2, 3, 4. Well, two research. No, 3. One research professor, 1 senior research scientist, several postdocs, a clinical coordinator, and an army of undergraduates.
Right. You answered this partially already. I was about to ask you, how do you have time to do research, teaching, coordinate the team, travel internationally to do lectures? I think one of the answers is you get up at 5 a.m.
Only on these 2 days.
The other days you sleep late till 5:30, I'll bet, right? But
no, I sleep till later because I work late. No. So I have several things. Well, first of all, I really travel a lot, and that's a huge part of my job. I travel a lot because I never say no to a clinical invitation. I don't. I feel it's very often I'm the only engineer at the clinical meeting, very often. And I love that. Well, I love it because I'm not the only person, the only faculty, sorry. I'm, so I typically will present our technology, and, I love doing that because that's my audience. I want to convince them. So I
Right.
travel because of that. I don't go much to engineering meetings. A long time ago, I made this choice. I have to convince people to use it and what its value. So that's a very big part of my job. How do I don't teach huge amount. I teach in the fall a large undergraduate class, actually a core class. That's called computational medicine cardiology, called cardiology. And so I talk a lot about what is the role of computational modeling in medicine and so forth. And so some of my experiences. So it's not a difficult class to teach. I have TAs, so they help, with that. And I'm quite busy with sort of being the director for AI research in health and medicine. So that is also busy. But how do I manage all that? The team for the clinical trial works like a little startup. They all know, everybody knows their task. We have a redundancy. If somebody's on vacation, you know who steps in. It's like before the procedure, they would brief the attending in the evening. So everything is clear. I don't even have to be on that Zoom. That part works like charm. I have to work with every student on their papers and everything. So I don't sit at their shoulder. So when somebody comes to my lab, and wants to be my PhD student, gets accepted, my first thing is, I cannot be hands-on, but you will get so much help in the lab. I'm not hands-on because I'm not there very often, but I will have my hands very strongly on once the results are done. Now, then I mold the paper into something, I love storytelling. I love to have, that's why we try to publish, we have a number of Nature Science contributions, the journals contributions, and I love sort of showcasing the very important and message that people can sort of identify kind of with, or see what their important contribution would be, sort of for the broad range of readers. I love crafting stories like that. I love public speaking. I love sort of showcasing the technology. And so writing papers like that, that's where I get it. I'm really on. But them getting the expertise of running the stuff, I have people in the lab to do that, to train them. I don't have to train them myself.
Right.
So how I organize the stuff.
So you're a great manager as well as all the other.
I don't know. I think the priorities that work right for what we are doing.
Right, you figured it out. You mentioned earlier about the Apple Watch, and there are studies ongoing now about using the Apple Watch to monitor arrhythmias. What's your feeling on that? Do you think it's a good tool for that?
I mean, any tool that will provide information about subclinical characteristics of AF, so people can be anticoagulated earlier and prevent stroke, is a good thing. What is the, we still have a long way to go, but in general, I believe that remote monitoring of any type is going to be a huge thing in medicine. It's going to be a huge thing. And that's where AI is going to play a really important role in sort of dissecting or getting the patterns from the data and providing early notifications. This is going to be very, very important. So the Apple Watch was the first sort of a big step in that direction, but I think a lot is coming.
Right.
Yeah.
Are you doing any imaging of the coronary arteries as well, like flow?
We are not.
You're not.
We're not. The coronary arteries, it's more of a flow problem. We have done some hemodynamic studies, but they have been mostly on stroke resulting from AF,
right.
Because you get, the stagnation of blood. So figuring out that and where exactly they occur and in which cases the left atrial appendage is involved and so forth. So we have some papers on that, but the actual blood flow in the vessels, we have not. That's not been our area of research. Yeah.
All right. So we've established that you're a heart expert, you know everything about the heart. So tell us what you do to keep your heart healthy.
Okay.
Yeah, very
I
important
try to
because we
exercise.
want to stay out of your lab.
Yes, stay away of my lab. Yes. But if you need to come to my lab, that's the difference. Yes. Yeah, I make an effort to stay fit and exercise. I actually like that. I like hiking. I like walking. I have a Peloton at home. I try. It's a priority, actually. I do, I feel really unhappy if I cannot, if I'm that busy. Like I was writing an NIH grant in May and I couldn't do anything, and made me quite unhappy to not be able to do my routines. But yeah, I would like to, I do try to exercise.
Right.
Also, I must say, the whole interaction with all the members of my lab, they're all young and they're getting younger every year, right? It's actually very kind of, I mean, stimulating and keeps you young
Yeah, that
in
keeps
outlook and
that keeps your brain young, but it's
yeah, it's also sort of you're part of this the social milieu of the younger generation, kind of. I love socializing with them. If I can find the time for that, they like it too, I think.
yeah, yeah, it's
So
stimulating for
that's,
them. They learn from you. It's
yeah.
interesting that you mentioned exercise as the first thing, because I've interviewed many specialists, doctors in different specialties, and no matter what disease or what specialty, exercise seems to be the best treatment for everything and the best prevention as well.
Absolutely, absolutely. I know it from my own experience, and it's the best cure, actually. There
Yeah.
are things that it won't cure, but for a lot of things, it's a perfect cure. Just the only thing is persistence, persevere,
Right.
persevere.
You have to
And
stick.
that's true for everything, not just for the exercise. It's true in like developing a technology that it's gonna maybe potentially become something big, not anytime soon, until you really be able to convince everybody and make it easier to implement. It's another thing that you have to persevere. So have priorities and persevere with them is my
Great. This has been very fascinating discussion. I learned a lot. I'm sure the audience out there has as well. And I think this is going to be huge. You're on to something very big. And I think in the next 5 years, maybe 10 years, that this will be done in every medical center around the country. It's going
We're
to
hoping
become,
so.
I think it'll be the standard of care.
Yeah, I hope so. You pull your records, EHR, and then there it is, your virtual organ. You
Right.
can see, oh, I want to do that. Oh yeah, this is what's going to happen.
Yeah,
Or,
it's going to be reproducible in every
right.
institution eventually.
Yeah.
So I want to thank you for all the great work you're doing
Thank
and
you.
all your
Thank you.
accomplishments. And thank you again for taking the time from your busy day before you go on your Peloton now to
I did it before
I
because I
did it
wasn't
for.
sure.
Well, thank you very much. Really appreciate it.
Thank you. It was really fun. It was wonderful to chat with you. Really appreciate it. Thank
All
you.
right. Thanks.